Welcome back to part 2 of our lecture. I changed my AI voice, hoping that it will make you more energetic. This part will be focused on cancer screening. I will use Thai guideline and USPSTF recommendations as my main references. You will see the similarity and contrast between the two guidelines. Keep asking yourself, why? Will help you see an impact of context on how recommendations were made. There are 5 issues you have to learn about each cancer screening: whom to screen, when to begin, which test to use, testing interval, and when to stop screening. The privilege of being a geriatric doctor is that you almost need not to care about the age that should begin screening, but you guys still need to care about that. Let's start with cervical cancer. The main screening test is Pap smear, recommended since young adult age. The interval of Pap smear is every 3 years. USPSTF also recommend HPV testing, which can extend the interval to every 5 years. Both guidelines recommend similar age to stop at 65 if previous screening has been performed. This age cut point is set because in average-risk women, if there has never been any occurrence of cervical premalignant lesion before, newer lesion is unlikely to occur beyond this age. While self-test is not mentioned in the Thai recommendation, Thai women can get free self-test from app Pautang, but the age limit is at 60. This self-test is important because it helps break one obstacle of cervical cancer screening: the hesitance to get examined by a doctor. Cervical cancer is considered a successful model of cancer screening, and it is very cost-effective. Why is that? Let's think about it. Are there any reason apart from the affordable test? The answer? Benefit. Cervical cancer patient tends to be young. Saving a younger patient from dying will gain a lot of life year back. And that life year is the currency of cost-effectiveness. You pay for a test, you save a person, and gain a lot of year back. Win! Next, another cancer of women, the breast cancer. Thai guideline recommend clinical breast examination, aka palpation by doctor. But USPSTF recommend mammography every 2 years. You can see the contrast? Again, why are the recommendations differ? I will give you some hint. Both tests are valid and can be used to screen for breast cancer. So, what is the difference? The answer is, again, the cost effectiveness. But there is one more factor: the willingness to pay. At a country level, if your country willing to pay a lot for a life year gain, your country will be more likely to find an accurate but expensive test acceptable. Thus, the recommendation depends on each country willing to pay. In fact, WHO state that both clinical breast examination and mammography have benefit. But if accessible and available, mammography would be the preferred choice. We can adapt the concept to our individual practice. If your patient cannot afford mammogram, clinical breast examination is still useful. But if mammogram can be performed, there is no need to do clinical breast examination. And because breast cancer patients are older than cervical cancer, benefit gained from the screening will be perceived as lower. Another point is the interval. USPSTF suggests a 2-year interval for screening. If you have seen others' recommendation before, including usual practice in Chulalongkorn Hospital, you will note that we usually suggest annual mammogram. The reason is also cost-effectiveness. But this time, the cost is not the price of mammogram per se. When we do mammogram every year, we can save more women from breast cancer death. But it comes with a lot of false positive results, leading to more tissue biopsy for benign lesion and also overdiagnosis. Overdiagnosis is a phenomenon where screening leads to discovery of non-significant cancer, which usually end up in non-necessary treatment. In this image, 3 patients actually have cancer, but only 1 has symptom and die from the cancer. The other 2 may die from old age without even know they have had cancer. But because of screening, we detect them and bring them to treatment. This overdiagnosis can also lead to false assumption of screening benefit in research. Because screening finds 3 cases and only 1 die from cancer, it may seem that screening reduced case fatality rate to only 1/3, while in reality, it does nothing. Next, colorectal cancer. Both guidelines recommend annual stool-based test, but USPSTF also suggests other tests. The most used alternative in real life is colonoscopy, which is set to be performed every 10 years. Let's consider a match between these 2 tests, stool-based versus colonoscopy. Which one is better? I will give you the answer. In average-risk persons, both are considered equal as cancer screening strategy. Give yourself some time to think about it. How come? How can a stool test be equivocal to colonoscopy, which can see the tumor and perform biopsy? Pause the video here if you want to guess. First of all, what you are comparing is not one stool test and one colonoscopy, but a strategy to do annual stool test and, if positive, go for colonoscopy versus colonoscopy for everyone. So it's a comparison of strategy, not a single test. Second, the parameter you want to compare is not sensitivity or specificity, but the ability to reduce mortality. There are no head-to-head comparison between the two, but estimation from studies found similar benefit. In fact, stool tests have less complication. Thus, be confident that the 2 screening are equivocal in an average-risk adult. Choose depend on preference. The important issue is that if your patient is at an elevated risk for colorectal cancer, colonoscopy should be the investigation of choice. So if the patient has symptoms, has history of cancer, has inflammatory bowel disease, you should suggest them for colonoscopy. Lastly, prostate cancer screening with PSA. Both guidelines not really recommend routine PSA testing. Why is that? You might be able to guess. Yes, it is the cost effectiveness again. Prostate cancer are old men. Minimal life year will gain from screening and treating. But not only the low benefit, the cost is also high. It is estimated that 1,000 men tested for annual PSA for 13 years will result in about 200 biopsies, 100 diagnoses, and 80 treatments. These treatments result in complications like urinary incontinence and loss of sexual function. The benefit? 1.3 deaths and 3 bone metastasis reductions from this screening of 1,000 men for 13 years. This is also an example of overdiagnosis. We're about to end part 2 here. There are also other cancers worth study: lung cancer, hepatoma, and cholangiocarcinoma, especially in Thai people. Before we get to the last part, try to answer this thought-provoking question. First, consider your patient can perform self-test for HPV. No need for pap smear anymore. Is the patient still need annual pelvic examination by gynecologist? What important is the reason? Try to come up with some idea and put your answer in Google Forms. Another question. You can see that with the exception of cervical cancer, I tend not to say anything about stopping criteria for cancer screening, even when some age cut point are included in the slide. I would like to ask you to think, without using any reference, when should we stop recommend cancer screening in an individual patient in front of us? If you have attended our clinic, please imagine those patients. Let's answer in Google Forms, and we will begin the final part.